Hi, and welcome to another episode of the Canadian Breakpoint, a Canadian infectious disease podcast by infectious disease physicians. I'm Summer Stewart, here with Dr. Rupeena Purewal, pediatric infectious disease specialist from Saskatoon. For this episode, Dr. Purewal will discuss Baloxavir in anticipation of the 2021 flu season. Dr. Purewal.
Hi, everyone. Welcome to another episode of our podcast, The Canadian Breakpoint. Today, we'll be discussing Baloxavir, which is an antiviral that was recently approved by Health Canada in February 2020 for acute uncomplicated influenza infections in those 12 years of age and older. And I wanted to review this topic for multiple reasons, one being that our last influenza season was very different here in Canada and probably globally due to many factors, likely an increase in flu vaccine uptake versus universal masking that's been in effect. Now, as many of us are aware, this winter season, or respiratory season, may look more similar to our normal respiratory season with some increased influenza cases. And therefore, I thought it was very timely for us to discuss a new antiviral that was on the market, Baloxavir. And therefore, that's what we'll be talking about today. Before I do start talking a little bit more about Baloxavir itself, I do want to mention that this is an informational podcast. I do not have any financial disclosures and am not endorsing this product. So today, our objective will be to learn about Baloxavir, also known as Xofluza. We will talk about the properties of Baloxavir, the indications, contraindications, and then in the end, we will compare it to our conventional antiviral, also known as also Tamiflu or Tamiflu. So starting off with Baloxavir, Balxoavir Marboxil is the active ingredient. So the product name is Xofluza, and the route of administration is oral. When we will be prescribing or using this as a prescription medication, it comes in a 20 milligram and a 40 milligram tablet. So in terms of dosing for us clinicians, if your patient is between 40 to 80 kilos, then 20 milligram tablets for a total dose of 40 milligrams. If they're greater than 80 kilos, then we're looking at 40 milligram tablets for a total dose of 80 milligrams. Fortunately, it's a single dose regimen that's given within 48 hours of symptom onset. Now, going on to the indications as were listed in the product's monograph, it's indicated for the treatment of uncomplicated influenza, as we mentioned, in patients that are 12 years of age and older, who have been symptomatic for no more than 48 hours and who are otherwise healthy or at high risk of developing influenza complications. There's no clinical evidence for efficacy outside of influenza A and B, so not recommended for other viruses. And again, there's no efficacy or safety that's been established in those that begin therapy or treatment after the 48-hour mark. Also, there's no efficacy or safety in treatment of influenza in patients requiring hospitalization. So those you would encounter more of your complicated influenza cases. And also kind of different from our also Tamiflu antiviral medication. There's no efficacy here with Baloxavir in preventing influenza. Now, going on to the mechanism of action. So Baloxavir Marboxil is a prodrug that's converted by hydrolysis to its active metabolite, Baloxavir. This active form exerts the anti-influenza activity. So it actually acts on the cap-dependent endonuclease, which is an influenza virus-specific enzyme, and actually the PA or polymerase acidic subunit of the viral RNA polymerase complex. So really the way it works is it inhibits the transcription of influenza virus genomes, resulting in inhibition of influenza virus replication. Looking at the pharmacokinetics of this drug, Baloxavir, the terminal elimination half-life of Baloxavir after your single oral administration dose is 79.1 hours, and it's mainly excreted via the fecal route in humans in small amounts in the urine. So obviously, as clinicians, I think it's really important for us to talk about efficacy and also safety. And so based on the monograph, they did discuss two clinical trials that we're going to talk about right now, but really basing it on that there was significant reduction in the time to alleviation or time to improvement of influenza symptoms with Xofluza compared to the placebo group. So the two clinical trials, so the first trial was a phase 3 randomized double-blind multicenter placebo and active controlled study designed to evaluate the efficacy and safety of Baloxavir compared with the placebo arm or also Tamavir in healthy adults or adolescents. That was your 12 to 64 years of age, weighing 40 kilos. All that had acute, uncomplicated influenza. So really the eligibility for this trial was that they had to have an auxiliary temperature of 38 degrees Celsius or above, one respiratory symptom that was moderate or greater in severity, and one systemic symptom like headache, fever, chills of moderate or greater severity. All patients in this study were treated within 48 hours of symptom onset as per the indications, and dosing was 40 or 80 milligrams of Xofluza, or conventional dosing for Tamiflu, and then there was the placebo arm. So really the design of the study was to do self-assessment, which would require to assess their symptoms as none, mild, moderate, or severe, twice daily in the first 9 days, and then once daily up to day 14. So the primary efficacy endpoint was time to alleviation of symptoms, and that was defined when all symptoms were assessed as none or mild for a duration of at least 21 and a half hours. So this specific study had an N of 1,400 patients that were randomized. The intention to treat infected population included over 1,000 patients with PCR confirmed influenza. I think it's quite interesting for me to look at the predominant strains in this study, and it was mostly influenza type A, H3 subtype. That was around 88%. And then coming in second was influenza B type at around 10%. And then with the smallest number was influenza A, H1N1. It was also notably mentioned in this trial that 75% of the patients enrolled did not receive their influenza vaccine. Now, when looking at the primary endpoint, which was that time to alleviation of symptoms, a statistically significant improvement was seen with the Xofluza group when compared to the placebo arm. But there was no statistical significance that was seen in any difference in time to alleviation of symptoms when we compared the Xofluza group to the Tamavir group. As for the secondary endpoint, which is time to resolution of fever, it was also noted that it was faster in the Xofluza group compared to the placebo arm, with a median time with the Xofluza group around 24 and a half hours compared to the patients that were in the placebo group, which was up to 42 hours. Now, as mentioned previously, there was two trials that were discussing the efficacy and safety. So the second trial was a phase 3 randomized double-blinded multicenter placebo and active control study to evaluate efficacy and safety, again, of the oral dose of Xofluza compared to the placebo arm or also Tamavir in adolescents and adult patients older than 12 years of age, now with influenza, who are at high risk of developing influenza-related complications. So the patients that were included under the high risk are kind of what we see in our probably clinical practice, but most commonly was represented in this study was underlying asthma, chronic lung disease at around 40%, diabetes at around 20%, and then followed by heart disease and obesity around the 12% range. What the patients that were excluded were if they had cancer in the last 5 years, untreated HIV, or treated HIV with a low CD4 count of below 350, immune suppressed patients following transplant. So really anybody really in your immunocompromised state. Now, most patients in this clinical trial also had not received their influenza vaccine. Eligibility was very similar to the previous study. And the number of patients that were randomized were over 2,100, and over 1,100 of them had confirmed diagnosis of PCR at the study entry. The predominant strains here were influenza A H3 subtype, very similarly, but there was more of a 50-50 distribution here, with influenza B coming in second. And when looking at the primary endpoint here, which is time to improvement of symptoms, there was, again, statistical significance for the Xofluza group compared to the placebo group. But again, no significant improvement difference that was noted in the Xofluza group and comparing it to the oseltamivir group. So very similar to our previous trial that we just discussed. In terms of the secondary endpoint, which is resolution of fever, fever was reduced more rapidly in the Xofluza group compared to the placebo group. So I think all in all, looking at both the healthy subjects in the first trial and the high risk subjects in the second trial, as we just discussed, the Xofluza group for both their primary and secondary endpoint did better than the placebo group, I think is what mainly I took from this study. And it was also, so as we mentioned in the second trial, they were looking at high risk patients who have a higher risk of developing influenza related complications. And so they specifically mentioned in the monograph the overall incidence of influenza related complication was around 3% in the Xofluza group compared to the placebo group, which was up to 10%. So that was another important measure. And really they had a lower incidence in these patients in the Xofluza group, lower incidence of bronchitis and sinusitis. However, there was no significant differences in some of our higher risk complications or more complicated presentations, such as death, hospitalization, otitis media, or pneumonia. So I think that overall summed up the efficacy of Baloxavir. In terms of, as clinicians, I think it's also really important to know the safety. And so looking at what the monograph stated, safety was submitted and reviewed by Health Canada, and safety and efficacy had been established for children that are older than 12 years of age and weighing greater than 40 kilos. So it was not well established outside of that age range and outside of that weight. In terms of pregnancy and breastfeeding, so definitely there are no well-controlled studies in this population, which is usually the case in most of the drugs that get released on our market. However, the current recommendations in your pregnant patients or those that are breastfeeding, there's no kind of well-controlled studies, as we mentioned. So the current recommendation is that we currently should not be used during pregnancy unless there's really a potential benefit that justifies the risk to the fetus. When they did look at higher doses of Baloxavir in, for instance, like pregnant rabbits, like at 6 times higher dose than what we would be giving to humans, they did see that there was maternal toxicity leading to miscarriages and an increased incidence in minor skeletal abnormalities, but this was not obviously seen in some of the other subjects that were used. And then in pregnancy, we just don't have those studies right now. In terms of any contraindications, so avoiding it in those that have any hypersensitivity to this drug or any ingredient in the formulation, such as anaphylaxis, urticaria, angioedema. I think it was important for the part of the monograph that mentioned kind of dosing considerations. You want to avoid giving it with any calcium beverages. So pretty much all in all, avoid dairy products, anything that could combine with the medication that would make it more or make it ineffective. Antacids were on the list, oral supplements like calcium, iron, magnesium, selenium, or zinc as well, and some laxatives that have polyvalent cations. So definitely taking that into consideration, especially for our pharmacy folks that are helping us prescribe this medication. They also mentioned in the monograph that it was not well studied in renal impairment patients and those with severe hepatic disease, but currently there are no change in dose recommendations So no dose changes required for both renal and hepatic impairment. In terms of side effects, so in the clinical trials themselves, they saw some mild side effects, like GI upset, which was a really common manifestation that was seen in those patients, including nausea and diarrhea, but also developing other milder symptoms of bronchitis, sinus infection, or headache. And when looking at it more so in the post-marketing adverse events, anaphylaxis, angioedema, urticaria, and rash were seen. Vomiting, bloody diarrhea, melena, ischemic colitis. However, as we're aware, these are reported voluntarily from a population of an uncertain size. So really can't reliably estimate their frequency, similar to that what we can do in the clinical trials. And it seems like in the clinical trials, really the milder symptoms were more predominant. However, with age, nausea was also a predominant finding. So that's something to consider in your patients when prescribing it. And obviously with any other medications, if there is any severe reaction, you should always counsel your patients to stop taking the medication and speak to the healthcare provider. So there was an interesting part of the monograph that was brought up in terms of resistance or development of resistance and treatment emergent amino acid substitution resistance that have something that they've been noticing in the US. So since FDA approval in the US, which is back in 2018, they are seeing that. Now, more so in vitro. In clinical isolates, really, it's the treatment emergent amino acid substitution and the PA protein, which showed mainly for influenza A virus isolates that there's a 10-fold reduced susceptibility, but not so much or not as high in the influenza B group, but still representing a 5-fold reduced susceptibility to Baloxavir. In the clinical trials in the healthy subjects, this mutation at this amino acid substitution position was seen in about 10% of the Xofluza group. In the high-risk patients, about 5% of the patients that were seen had this mutation detected. So just something to consider when we are looking into prescribing. So kind of the evidence or the supporting kind of recommendations that were given in regards to that was that health professionals should consider available information on the influenza virus drug susceptibility patterns and treatment effects when deciding whether to use Xofluza, if that's an option. And so kind of pretty much wanted to sum up this episode by comparing Tamiflu to Baloxavir, because I think most of us are quite aware of the properties of Tamiflu or also Tamivir versus Baloxavir, but really doing a side-by-side comparison can sometimes help, especially because these are the two antivirals that are on the market. Most of us may not be familiar with Baloxavir because it was just released prior to the COVID pandemic. And since we didn't see much influenza activity in our last respiratory season, a lot of us probably did not prescribe this medication. However, we may be seeing a different respiratory season coming forward in these winter months. And so we'll just end this podcast by talking a little bit about Tamiflu versus Baloxavir, some of the properties that stood out to me and will help me as well in my clinical practice. So when we talk about cost, I think it's always an important topic to bring up when we're comparing medications and when we're prescribing medications. So both of them are prescription drugs. Tamiflu is less costly, whereas Baloxavir is more expensive. So that's something to consider. In terms of the mechanism of action, Tamiflu, as we're all aware, stops the viral copies from leaving your cells to preventing you from becoming more sick. Whereas Baloxavir, as we just learned, stops the influenza virus itself from actually making copies of itself, so the viral replication. Now, both of them, it's advised to take within 48 hours of feeling sick. And I think as a pediatrician, it was actually quite important to me to know that Baloxavir is only approved in those older than 12 years of age and greater than 40 kilos. Whereas Tamiflu, and what I see in my clinical practice as well, is we can give it as young as 2 weeks old. And not only that, but we can use Tamiflu or also Tamivir as a treatment and prevention agent, whereas Baloxavir, as we just learned, is only indicated for treatment. And just kind of remembering that Tamiflu can be given for your complicated patients and is recommended, whereas Baloxavir is more probably in your outpatient setting where you have an acute, uncomplicated influenza positive patient, maybe somebody who is higher risk for developing complications, or even in our pediatric populations in that adolescent group. If you have a patient where you can detect them within the first 48 hours of feeling sick and can give them a single dose, probably helps with compliance that it's a single dose as opposed to Tamiflu, where you're taking it for 5 days, twice a day dosing. That's probably the conventional dosing. Now, I did want to kind of touch on the topic of antiviral use in general, because in the pediatric population, we often kind of shy away from giving antivirals, especially Tamiflu, which has been on the market for a long time. And recently in the pediatric journal, there was a study that was released by Impact Network, which is a pediatric hospital national active surveillance network, which is actually a really good paper that sums up kind of the antiviral use in the pediatric population. So it's only looking at from 0 to 16 years of age, and was comparing our use in 2010 to 2011 compared to 2018 to 2019. Now, overall, our use of antivirals, despite the current recommendations from Canadian Pediatric Society and the American Academy of Pediatrics, stating that antiviral agents are recommended for influenza, especially in patients that are hospitalized patients, even if they've are past that 48-hour mark. However, our overall use in our pediatric patients, when looking at the over 7,500 cases, we were only at around a use rate of about 41%. So definitely could be variable among centers. Different centers have different abilities for testing, and those that can test sooner obviously had higher rates. So something to consider. So just coming into this respiratory season and likely our influenza season, that's something to consider. And when they looked at the antiviral use rate in these pediatric hospitals, comparing it from the 2010 to the 2018, 2019 data, we did see that the overall use had increased. Now, whether that's, again, because of more testing or more complicated patients, for many reasons. So it went from 20% up to 60%. But I just wanted to kind of bring that up because definitely there are benefits and a lot of observational studies that have been seen in children and adults that are hospitalized that suggest clinical benefit of antiviral use. Now, whether that's decrease in length of stay, decrease in healthcare costs, and decrease in our ICU and overall mortality, morbidity. So something to consider for us as clinicians as well. And knowing kind of the indications for each of the antivirals that are available to us on the market, I think was one of the first steps for me, just knowing and learning about Baloxavir, because it was something that I definitely have not encountered in my clinical practice. Just kind of remembering that. Now, obviously, we detoured a little bit more of talking about hospitalized patients, whereas Tamiflu would be the indication there, and Baloxavir is only used in acute, uncomplicated setting. Now, finally, just what we have on formulary. So in with Tamiflu, it's a liquid and tablet that's available, and that's probably more beneficial for us pediatricians out there. In terms of Baloxavir, there's no liquid formulation that's available, but they do have a tablet form. Unfortunately, cannot be crushed. So considering that in your acute outpatient setting might be an important, may weigh in your decision when prescribing either of these antiviral agents. Definitely with Tamiflu, there was less side effects, as we're quite aware with, pretty safe drug, less side effects. Usually the side effects are nausea, vomiting, which get better with food. So always counsel your patients regarding that. And then in the Baloxavir group, we discussed some of the side effects. Again, nausea, GI upset were predominant, but we're likely maybe encountering more side effects in that with that agent compared to Tamiflu. So that is basically what I wanted to discuss today. And as usual, we are very grateful to have this podcast up and running. Definitely would like everyone to reach out to us via email and let us know what you're interested in listening to. I would love to hear your thoughts, your comments on any of the episodes. or any future episodes, if you would personally like to come on to the podcast and discuss an important infectious disease microbiology topic, please do let us know. And thank you. Thanks for listening.
Thank you, Dr. Purewal, as well as Verity Pharmaceuticals for the generous sponsorship. Follow us on Twitter at CA Breakpoint and email us at thecanadianbreakpoint@gmail.com to suggest infectious disease topics or discussions you'd like to hear. We look forward to seeing you again at the Canadian Breakpoint.